We'll introduce the next speaker. The topic is a really important one, racial variations in SVR and CPO measurements in cardiogenic shock. Dr. Burke, take away.
Thank you. I want to thank Dr. Jumian for the invitation. I was very happy to see that I wasn't discussing pressure volume loops this year. And then I saw my topic. And so I was asked to talk about racial variations in SVR and cardiac power output. So the first thing I did, I went to my office, I opened up PubMed, and this is the first thing I saw when I did that search. I thought, okay, this is going to be a very short talk. Then I looked up SVR, and I said, oh, it could be even shorter. But I have full 7 minutes to fill, so let's see what I could do. So then I looked up the definitions, because in PubMed, sometimes you have to be very specific. So I started with variations, and you could see the definition there, what I thought was the more appropriate one. I also looked at synonyms, and the synonyms for variation are differences, is one synonym, or difference. And you could see here, distinct in nature or form or quality. And then I looked up disparities, which was also listed as a synonym. And here you can see, I think we have a little bit of difference, especially as we use it in our current context. So I also started looking at disparities in my search. But what I did find as I first went through, the first paper that actually popped up and out of interest I looked at was cardiac power output and cardiogenic shock. This is a sub-study from the shock registry. And then I spent time looking at table 1. So I spent a lot of time looking at table 1s for this talk. And you can see here, while they note the male gender, male sex, they don't say anything about racial categorization. So I said, okay, so then I'll have to go on. And the next discussion paper I found was one by Yakub, who has done a lot of work in this area. And this shows in these disparities, this title was Racial Disparities in race and, sex. It talked about STEMI and cardiogenic shock, and you can see here that there clearly were differences between men and women and differences in their outcomes, and also there are racial and ethnic differences. Then looking further on, you could see that there are significant differences among the groups as they separate them out, but we really don't know what the differences are actually between the groups in some of these outcomes. And they separate, again, if you look at the top, it's men, women, and then through their race. So now we're dealing with a couple of different variables. What was interesting to me when I got to the conclusion of this paper, while the title of the study was Racial, Ethnic, and Sex Disparities, the authors in their conclusion used the word differences, which I think is fair, but again, going to the definitions of the words and how we use them. So it did say that there were significant racial, ethnic, and sex differences in procedural utilization and clinical outcomes with STEMI and cardiogenic shock, women having a higher mortality, et cetera, and then Black and Hispanic having, as well as women having higher mortalities and lower procedural utilization. And again, in this same study, this is, a separate study looking at regional variations and also racial or ethnic categorization. And I just show the difference now is that we could see between 4 different regions in the United States, and I should note that both this study and the prior study were using the nationwide inpatient sample, which again is based on discharge diagnoses. These are fairly large data sets. This one, I think, was 400,000. The one prior to this, Yakub's, was 150,000 patients over a number of years. So now, not only do we have sex-based differences, we have racial differences, and now we have regional differences. So now we have 3 different variables to try and figure out if SVR and CPO are different. And I haven't been able to find that, to be perfectly honest. So I think we could end here, but we have more time. So an interesting study that then showed pathophysiologic vasodilatation and cardiogenic shock effects on mortality. And as I went through this, the interesting part was they broke this up even further. So they had now they had white, they had black, they had Hispanic, they had Asian Pacific Islander, and then they had other. So again, you can see there are no significant differences in the group, but the fact is the vast majority of these patients were white male, I think 80%, and the rest of them were very small numbers. So even as we look through to see if we can get any data on racial or ethnic differences, the numbers become very small in many of these large trials. This was a single center trial of 700 and some odd patients looking at SVR, low SVR, high SVR, and normal SVRs and their outcomes, which by itself was a fascinating paper, but I think the issue is we're asked about the differences, and that's how I got to this paper. And again, looking at, in this paper, they had a large breakdown of a lot of data, pharmacologic management, lactate, a lot of labs, a lot of variables, but none of it was broken up by either racial or ethnic, categories. So to answer the question that I was asked, we still don't know, but I brought this out only for the point is that there is information here that we probably could glean as we go through this. And again, what they did find was they used the sky shock categorization, which, again, is both racially, ethnically independent, and showed, again, with SVR in the different sky shock categories, the lower the SVR or non-responders in SVR, the higher the mortality, which by itself is a physiologic interest, but doesn't answer the question. And then just to throw in variability, to get SVR, for the most part, you need to have right heart catheterizations, pulmonary artery catheters in place. This, again, you've seen this slide before. We were part of this. I think our institution fell somewhat like 3/4 towards the right. But the reality is, as you all know, a large variation in the utilization of right heart catheterization and other hemodynamic measurements. So we know there's lower procedural utilization in racially separated, and we also know that there's just low utilization of right heart catheterization. In all these trials, it was anywhere from 15 to 20 some odd %, which is, again, fairly low to try and answer this question. So in summary, trying to save time here, there is no definitive data on racial or ethnic variation in SVR or CPO and cardiogenic shock. I do think that we have limited data sources, that this is all based, much of this is based on discharge data. That's not really helpful. There are both within group and between group differences likely, but we can't tell that there is because we can't separate that out. And how do you separate regional variations versus ethnic variations versus sex-based variations? So I'm left with almost the previous speaker. Are we asking the right question? So really we should assess and reduce the variation differences in clinical care. I think we should promote the use of best practices in cardiogenic shock care, much of which we're discussing at this meeting, and then promote personalized management. I think really that's where we go. When we're at the bedside, we're looking at an individual patient, and I think most of us aren't saying, oh, this is an Asian Pacific Islander, we have to treat them a certain way. We're looking at their numbers, their SVR, their output, their index, their pharmacologic responses. We now have the expert consensus statement. I throw this on only because I think we now have a good idea of what best practices, at least at this point in time, should be. I think we have to use those. And then just to finish, I think we have data sets, the Cardiogenic Shock Working Group and the C3TN, where maybe we can go back and look at some of that registry data to try and glean an answer. So I'm going to stop there. We don't have the data, but hopefully we can get it in the future. Thank you.
So this is for the panelists. This comes about quite a bit because there is an entity of shock, especially in African Americans, southeastern United States. So the reason which comes about is because the criteria for listing is basically a combination of low blood pressure, low cardiac output, and elevated wedge. So African American specifically entity is there's a significant mismatch between LV and aorta. So even if you decrease the afterload in these patient population, they're still in extreme shock. So that is, clearly there is an ethnic variation, so I'd like the panel to kind of dwell on that.
Yeah, I think we have to, when we're trying to get our patients listed, these African-American patients typically are extremely hypertensive, even though they're in cardiogenic shock. So we're having to give them some hydralazine to drop their blood pressure and see if we can have them meet criteria. So I think I agree with you, it's a silly criteria to get them to meet status 2.
So I appreciate the question. Much like James, I was intrigued by the title, and I think it's independent of race in the context of this afterload mismatch therapeutic prognostic opportunity when reporting out the hemodynamic profile. And one thing I liked about the title is SVR was front and center. And so I think there may be something, you can't tease it out in the peer-reviewed literature. We just had a thorough examination about the African American perhaps propensity to have excessive afterload. But I think independent of its underlying race, I think you're obligated to understand the implications of increment in output and clinical stability by vasodilating pharmacologically, even in the presence of lower blood pressure. That's good old-fashioned tailored therapy, and we can talk about the tailored therapy basic principles. But James, I'm interested in your take on this SVR prioritization.
You know, my own opinion, I think the data exists. I skipped through the slide, but you know, can we scrape some of our registries to try and tease this out? Can we use machine learning, or can we use the EMRs that we have to actually do slice or dices in our EMRs, looking at some of these patients, especially we have large populations in transplant centers, at least, and can we look at, you know, what's the initial response to I'm a pharmacologist by training, what's the initial response? Because not every, I think there'll be differential responses in terms of pressors, for example, and, you know, can we tailor that? So I don't have a good answer.
But from a practical perspective, if I may real quick, independent of race, if we have excess SVR, you know, I see in the ICU, oh, let's put them on a balloon, let's start ionotrope, let alone use of nipride or vasodilate. And I don't think there's consistency or buy-in independent of race. I think that's where there's an opportunity to better message.
I agree with that, 100%. Thank you.
I think we better move on. Thanks for a great talk.